Hello, everyone. Welcome to this month's webinar in our series hosted by CreakyJoints and Arthritis Power. My name is Corey Greenblatt, and I am the Manager of Policy and Advocacy for the Global Healthy Living Foundation, CreakyJoints. This month's webinar is titled Putting Patients at the Center of Care. Patients with chronic complex health conditions experience better treatment outcomes when provided with access to services and treatments designed for their unique needs. This webinar explores common problems patients experience and how the healthcare system is responding to provide solutions intended to help people get better faster. We are very fortunate to have Ashley Newton present with us tonight. Ashley is the Vice President of the Center for Clinical Excellence at the Centerstone Research Institute, and she aims to remove barriers and improve the experience for those accessing and providing behavioral health care by giving them the best tools science offers. We're very happy to be joined by Ashley tonight and learn from her expertise. And with that, I'll give over to control to Ashley and let her begin.
All right. Oops. And I think, can you see my screen?
Yes, we can.
Excellent. Thank you. Well, I appreciate you all letting me join you tonight. I'm excited to be here. As Corey mentioned, in my professional life, I work in the behavioral health field. So we work with individuals with mental health diagnoses. So I'm joining with a provider perspective, but I'm also joining you with a patient perspective. I'll talk a little bit more about some of my experience as a patient as it relates to this presentation, just throughout the presentation. But I was diagnosed with RA and pseudo-gout in 2016, so I'm still rather new to the diagnosis. Wanted to talk with you guys a little bit today about integrated care and why it's important, what it is, and how it impacts long-term treatment outcomes for patients. And so when we talk about integrated care, we're not talking specifically just about behavioral health. Just wanted to point out that we're really talking about patients across that are accessing care for any of those three reasons. This is my presentation is not specific to behavioral health care, even though that's where I sit in my professional life. A little bit about kind of the problem that we're facing is that we understand based on the research that's available to us that patients who do have mental illnesses, they actually die on average between 10 and 15 years earlier than those without mental health disorders. And that's per the World Health Organization. That's a huge problem. And we also recognize that a large number of those with mental illness also have chronic physical health conditions. So certainly not everybody with a chronic physical health condition will also experience a mental illness or a behavioral health condition, but there are a lot of, I think, links between those patient populations. We also understand that more than 1 in 5 adults with a mental illness will have a substance use disorder at some point in their life. And so historically, when we look at the way that we've provided care, what we find is that care is really provided in silos. So you may have I know I personally have a collection of specialists or doctors that I see for different reasons, but there's not really a point in time when those providers are coming to the table to talk about what they can do to really help me as a patient to achieve the best possible outcomes long-term and the best possible quality of life. What we know based on research is that taking an integrated approach toward care actually helps us to achieve that in partnering with our patients. So when we can bring those three kind of care sectors together, our patients actually stand to gain the most. It does require us to practice in different ways, to provide services in different ways. And some of that, while it feels logical, it makes sense to providers that's really what we should be doing, there are barriers that stand in the way of doing that. And so we'll talk a little bit more about those throughout the presentation, but I do want to point out that it's not only about your actual interaction with your provider. There are lots of things that impact that. the way that we share data, the way that we as patients experience care, the kinds of services we have access to, those all become how we use technology-enabled care. All of those things play a huge role in how we can better deliver integrated care, because in many cases, those are the things that the technology-enabled care, for instance, that really gives us the tools that we need as providers to improve that experience and to be able to do that for large populations of people. So I in this presentation did want to take a moment to kind of center ourselves around the patient experience, because at the end of all this, that's really, I think, that's certainly what drives me in my professional life, is that the very strong desire for people to get better faster. We as patients deserve access to really good care. And we all want, a really high quality of life. We want to be able to experience positive outcomes, regardless of where we're entering the care system. So I wanted to take a moment to ask you each to think about what your life looked like before your condition, what your experience was like following diagnosis, when you first learned of your condition, whatever that is. And then also what your patient experience has been like. How did you manage to route through the care system? Because my gut is that those of us who have been in the healthcare system for a while, your experience today and your what you're willing to advocate for yourself as a patient probably looks really different than it did when you were first diagnosed. Likely we've all learned some things along the way that have improved that experience to an extent. So the photos you're seeing, obviously, these are of me. Wanted to share a little bit about my patient experience with this group. I was diagnosed with RA and pseudo-gout in early 2016. Prior to my diagnosis, I, several years before, actually, had kind of recommitted myself to my health. Started really paying a lot of attention to what I put into my body in terms of food and nutrition, had picked up running, and actually was doing quite a bit of distance running. So I'd run a couple of full marathons and that sort of thing. In early February of 2016, I had an injury to my knee, and actually I just noticed a slight twinge to it. Didn't think a lot of it with it, but within 48 hours, I was unable to bear any weight. I was unable to walk unassisted, was unable to bend my knee. And like anyone, I showed up at the hospital and was then referred from provider to provider to provider. And while I think that they did the best that they knew how to do, I had a somewhat atypical situation, and nobody could really figure out quite what was going on. So it turns out I actually had a couple of different underlying conditions that had previously been undiagnosed, untreated. And so when that was coupled with I'd injured my meniscus, actually. I had 2 tears in my meniscus. And so when it was coupled with that, as a patient, what I experienced was a seemingly like sudden onset of symptoms. In reality, because those things had been untreated for so long, it created almost like a snowball effect. And so I very quickly realized that I was actually pretty sick, and that my providers were feeling a little bit stumped in terms of how to best treat me. And so, I was kind of shuffled around. So I was in a wheelchair or on crutches for about 7 months. And in that time had an earlier surgery to repair the meniscus. That surgery is not largely supported by research in terms of always its effectiveness, but that really wasn't communicated to me by the provider. And so I wasn't really able to make an informed decision as a patient about what I thought should happen in my healthcare. And also, as a result of that surgery, I sustained a staph infection in my knee joint. And so the ultimate fix for me, if you will, was a total knee replacement. So if you think about, patient profiles and how that changed, my life was kind of turned upside down. And hopefully that's not what everyone's experience. That's hopefully an extreme case. But I went from running, within 48 hours, I went from running full marathons to living practically in a wheelchair. So, like I said, I do think that, our providers, they do the best they can for us in trying to help treat those conditions, but I didn't have access to an integrated care approach that really could have impacted my long-term outcomes. So I mentioned a moment ago that we historically we've operated in silos in terms of the behavioral health, the healthcare system. There are commonalities that we share that I want to make sure that we focus on as well. There are also common challenges that we experience that we'll talk about in a moment. Some of the commonalities that I really see across each of our sectors, whether you sit in physical health or behavioral health or substance use, we as providers, we're driven to understand the unique needs of our patients because we really want people to have access to the best care, and we really do want them to get better faster. To do that, we understand that we have to understand what factors impact their recovery, because we want to help to, when I say predict relapse, that can be relapse relapse from something like arthritis. It can be relapse from a substance use disorder, from a behavioral health disorder. I think that word relapse really can mean different things depending on what your patient experience has been. And then finally, we are all experiencing kind of this transition to consumer-driven care. So we as patients want access to care in new ways. So if you think about some of the new services that are available around, like Talkspace, which is a therapy service that you can access by text message. That's something that's really new and unique that we wouldn't have had without some of the advances in tech-enabled care that we have today. I think the other thing that we see is that as patients, we want our providers and the healthcare system to interact with us in new ways. In addition, in terms of, like, when I go to my provider, for example, I want them to talk with me about the treatment options, and I want them to hear from my perspective, like, what's the most important thing? What does recovery mean to me? And how can they help me to achieve that? So it becomes more about a partnership and how we can help people to really meet those goals, versus somebody or a provider saying, first you're going to do step one, then you're going to do step two, and not really providing you any information about how those things work or how they might work for your unique needs. So I do want to look also at some common challenges that we experience. The first is that it can be really expensive to get treatment. Not a surprise. We also recognize that treatment is unevenly distributed. So as an example, therapy as a service for behavioral health is pretty easy in terms of it being available, is much easier to get to in the north than it is in the south. We recognize that there are some specialties that are harder for you to find as a patient, and you may be required to travel or to participate in like a telehealth service delivery because you can't access someone face-to-face. So all of those things really impact the kinds of care that we experience as patients. Second, we know that diagnoses are not always accurate the first time. This was certainly true in my experience as a patient, but I actually see this as an industry problem. In the behavioral healthcare space, there's a recent study that showed that for a population of individuals who were diagnosed with bipolar disorder, that up to 60% of those received their initial diagnosis was incorrect. And on average, it took about 10 years for them to get the correct diagnosis. 10 years is staggering to me. That impacts a lot. It impacts a lot about our care. Understanding someone's diagnosis is what allows us to make informed decisions as providers about what kinds of care is going to produce the best outcomes, what kinds of medications might be most appropriate or most helpful. And so, not having that information correct for 10 years really, really impacts the experience of our patients. Third, treatment isn't always rigorous. And this actually ties into one of my later points about evidence-based practices, but for a variety of reasons, the treatment that we deliver in the behavioral healthcare system doesn't always follow protocol. Some of those factors are unique to individuals, and you really are trying to meet patients where they're at in terms of what their needs are. Sometimes you can deliver an evidence-based practice that's shown to have really good outcomes and good results. But if that person can't get to you for appointments, or if they can't access that care, then treatment kind of starts and stops. And so it's not just about the provider or just about the patient, but how those two things are really working together in partnership. In addition, we notice that there's this kind of this better but not well category. So I think a lot about quality of life when I think about this. So in my personal life, my RA is not in remission. I'm not in a wheelchair anymore, so I'm doing much better. But my life today doesn't look anything like it did 2 or 3 years ago. So the way that I define well might not match the way that my provider defines that. And we certainly see this in behavioral health care and in physical health care, where we can get someone where they're functioning better, but we may not be impacting their quality of life to the extent that we really want to if we're going to help them to meet their goals as a patient. Next, we recognize that evidence-based practices in behavioral health are not widely adopted. There are a couple of reasons behind this. One of those reasons is that the science of care changes rapidly, and providers don't always have access to the kinds of information that help them to incorporate new treatments, new effective treatments into their practice quickly. There's like a 13 to 17 year science to service gap currently. And so that means that when we learn through research that something is effective, it can take up to 17 years for us to actually do that practice in real life and in the care we provide. And actually, there's a survey recently that Open Minds, it's a behavioral health consultation company, they surveyed that only 33% of patients reported having access to evidence-based care, which is a huge problem. Finally, we have a lack of continuing education for providers. And I think that others on the call maybe have heard of this before, but it's why we call medical practice a practice. You know, the science of care evolves rapidly, whether you are in behavioral health or physical health. And so if our providers don't have access to the kinds of tools or trainings or ongoing educational opportunities that help them to stay up to date with you know, the present day best practice treatments, then they continue to do what they learned in school. We also see a lack of care coordination between providers. So I mentioned in my experience or early in the webinar that at no point were my providers getting together in a room and saying, how do we best treat this person, or emailing each other or calling or anything, right? So this is certainly true across the healthcare system. So patients, in our experience, I think we often end up being kind of the go-between. So I will go see my rheumatologist, and then when I go see my primary care, they say, well, what did the rheumatologist say? But they're not actually connecting with each other. And the way that I explain something is likely very different than the way that my rheumatologist could explain it. So it's kind of like that game of telephone where the message changes the more people it has to go through. I've also got kind of 2 points here that I'll show about outcomes and data. In the behavioral health space, we historically have not been good at tracking outcomes. Again, there are several reasons for that, but I would say one of those is that there's a lack of consensus about what does getting better mean, and is that a number on a scale? Can you see it? You know, what does it feel like? And so, if for some diagnoses we have tools that allow us to assess that accurately, but with other diagnoses we really don't. And so, I've heard behavioral health in the past kind of referred to as like a kind of like a feel-good service, like you want to help someone feel good. But really there are ways that we can measure and track to what extent we've been able to help someone improve in their life. So the challenge there is really on getting providers using that more accurately, and then helping them to understand how to use outcomes and data to make treatment decisions. And then finally, we experience this notion about passive data. I know that's been a hot topic lately. There are lots of opportunities for how we might use passive data in ways that could greatly impact our lives, but there are lots of concerns about that too. And so, you know, privacy concerns are controversial at best currently. So there are products that we've looked at at the organization that I work with, where they're looking at how can we use data from passive data from your cell phones or from Alexa, or lots of these different kind of tech-enabled tools, but we don't have like policies or clear direction always on when is that appropriate and when is it not. And I would say that's true across the industry, not specifically just to behavioral health. So one thing for these common challenges that I really like to note is that there are lots of challenges that we all experience. I really do see these as, if we recognize these as providers, these are our problems to solve. These are the things that prevent people from achieving the best possible outcomes, and I see it as the responsibility of providers to be able to move the needle on these so that people can really get better. So I do also want to talk about a couple of common solutions. What you see here are visuals for a patient-centered medical home, and then on the right in blue is a behavioral health home. This notion of integrated care, this is really how both the physical health and the behavioral health sides have viewed what integrated care looks like. And so the notion is that the patient really is in the center, and then you're wrapping services and supports around that person, and each of those components are talking with each other. So instead of having one treatment plan from a primary care doc and another treatment plan from a rheumatologist, and yet a third one from a therapist or whoever else is in your healthcare system, we're really asking that they're working together to coordinate those plans so we're all working toward the same goals. Some of the ways that service looks inside of this are a little different. There's a greater focus on population health and how we can impact both at the individual and the population level. How can we impact care for them? There's also an emphasis on reducing the cost of care, and help measuring to what extent we're able to help people get better, and really holding providers to that. So if you are treating somebody and you're not helping them to get better, then there are penalties as a provider for that. If you're able to help them get better and you can reduce cost of care, then there are incentives for that. So aside from, I would say, care coordination, as a patient, care coordination is probably one of the things that you would notice that's different about this kind of care, meaning that all of those providers are talking, they're really trying to partner with you to look at what does your care look like and what can we really do that's unique to you, that's going to help you to get the best possible outcomes. The other thing that we're seeing at the industry level around integrated care is that health plans are getting behind this, and they are looking for new ways to pay for services that allow for providers to really do integrated care and to do it well. I mentioned before that a good bit of this has to do with how we share information and data. And so health plans have come to the table to really talk with us about how might we do this together, versus saying you as a provider are responsible for these things and you need to go figure it out. But it does have a direct impact, I think, on our experience as patients as well. So I do want to point out, so patients are unique, right? We have complex needs. If you think about two people presenting with the same disorder, they may present very differently. I mean, I could look to myself, my own experience as one example. If you hear that someone has a diagnosis of, something like RA or any other disorder, my quality of life was very different. Even in my own, I would say myself 2 years ago versus myself today, those two presentations are very, very different. And I think that presents challenges for our providers in understanding what's happening, how severe the symptoms that we're experiencing are, how it's impacting our quality of life. You can't look just at what's on paper and really understand what that person's needs are, what their experience has been. And that's certainly true in behavioral health care as well. There are some contributing factors to this. So things like health hygiene. So, how much quality sleep do you get? What is your nutrition like? The kind of your self-care mechanisms. Those things certainly play a role. We know that genetic predispositions also play a role. We've stated earlier that comorbid and co-occurring disorders, so comorbid meaning a physical health and a behavioral health condition, and co-occurring meaning a substance use disorder in addition to those. Having more than one kind of condition drastically changes your long-term outcomes, and it really indicates a need for different kinds of treatment than if you were to present with just a physical health disorder. The final thing on this list I would like to point out is the social determinants of health. We're actually going to talk more about what those are, but these are essential. They're health inequalities. And I'll show you guys here. So this is Kaiser Permanente's definition of what social determinants of health are. I think historically, when we've talked about social determinants, it's really easy to equate this to someone's socioeconomic status. In reality, it's much, much larger than that. So the kinds of things you see here, like there are factors that are related to your employment or your income, but there are also factors that are related to things like your health literacy. You know, when a provider talks to you about the treatment that they're recommending, do you really feel empowered to ask questions or to understand how that might impact you, or whether that's the best possible choice for your care? There are also things on here like access to healthy food options. So we, depending on where you live geographically, we recognize that we certainly serve lots of patients who live in what we call like a food desert. So meaning there's not a grocery store that they can easily get to, without having their own transportation or a vehicle. And so it may be that their only option is to pick up, a corn dog at the local gas station. And so these things really do play a large role. And in my next slide, I'll show you. These account for about 50% of our outcomes. I think for providers, what is helpful for us to think about is what of these we can move the needle on. So there are some of these things that we are actually quite skillful at. I know certainly in the behavioral health space, we talk a lot about things like social needs like food, transportation, safe neighborhoods, employment options. Those are things that for a long time we've been working with patients to help them to be in more stable environments or to have access to certain resources that they may not have otherwise had. There are other things, I know that doesn't really fit as easily when I think of like a physical health, like your primary care doctor. I don't know that I've ever had my primary care doctor work with me on getting a job or any of those things. But there are things listed that they can really can certainly play a huge role in impacting. So helping client or patients to think through, if we're recommending that you change something about your diet or your exercise, how can they actually do that? And thinking through what that really looks like and planning for that. I think the notion of health literacy to me feels really big. So the way that we talk to patients about what our recommendations are and really creating a space where they can partner with us in terms of thinking through what might fit best or best meet their needs, that has a huge impact on their overall care. So a moment ago, I mentioned that social determinants of health, they actually impact our overall health outcomes by about 50%. So if you look to the right, your physical environment accounts for about 10% of your overall outcomes, and then the social and economic factors are in there again at 40. And so the other things, so like actually, tobacco cessation or changing things in your exercise plan, they make an impact, but they only account for a portion of it. And so when we think about the way that we treat patients, having that integrated approach where we really are treating the whole person, inclusive of social determinants, we have a huge potential to help move the needle both on their long-term outcomes as well as the total cost of healthcare, which is always a hot topic. So We are seeing, as in the kind of the provider realm, we are seeing that health plans are recognizing the impact that this has. They're looking for feedback or ideas around how they might support that work. And so we are seeing more interest in how we can account for those inside of the way that they structure contracts. And that's definitely, I think that's something that's new and different. The other place that we see this is with regards to policy, like federal policy. The organization that I work with, we routinely take calls with congressional offices and policymakers about how can we create policies and programs that incent providers to focus on social determinants, given the impact that they have. So when I think of social determinants, it's easy to think of those kind of at the personal level, like at the patient level. The other way that we think of these is at a population level. And so if this is kind of how we think of where patients fall in terms of like a risk management strategy. And this is also what health plans are looking at, and this is helps guide decisions about what kinds of contracts they offer, what kinds of services they offer inside of that, what they'll pay for providers to provide to patients. And so it really is kind of a critical concept for us when we look at this triangle, here on the left. This top 5% that's here in red, this makes up what we sometimes call a super utilizer population. The top 5% account for the large majority of healthcare spend across the U.S. every year. This can be a challenging population to treat. Integrated care does make a big impact for this population, but there are things that we understand now about this population that help us to understand how better to approach treatment for them. So one thing that's important to note is that this is not a static population. So the year that I had 2 surgeries, including a total knee replacement and all of that, I was certainly in this top 5%. The rest of my life leading up to that, I had probably been down in this lower part of the triangle in the green. I went to the doctor once a year. I was pretty healthy. I didn't really notice a lot of other needs that were surfacing. And so the way that we treat patients, depending on where they fall in this, is really different. There are certain kinds of services or strategies or interventions that we can offer that help them to both move down in terms of their risk level, but what that means for a patient is that means that you're becoming healthier. So, and I want to ask, bringing things back to the patient perspective. In your own life, what does getting better look like? I think about this often in my own life. I mentioned earlier when we were talking about common challenges about the need to identify which outcomes matter and how to measure those. And so this top question, how do you measure mental illness? You could ask 5 people and get 5 different answers. But we do have tools and assessments today that are based on research that help us to start to measure that. And those are tools or assessments that we use with patients, with them at the table, because you have to have their perspective, and you have to have their story as a part of that, because a number on a scale might not mean better to me. That might mean better but not well, whereas to someone else that could meet their personal goals for their own recovery. So just getting the measures in place and getting data in place is really only kind of one component. It doesn't really matter what you measure if you don't use it for something. So as providers, we have to understand what story the data is telling us. When I think of this as a patient, I actually talk about my experience in using the Arthritis Power app quite a bit, and I use that in my own medical care as well. So I complete my measures and I take those to my providers frequently, and talk through what it means and how do I interpret what I'm seeing inside of that app in consideration of what do I want to accomplish inside of the treatments they're providing me. And we use that information to make decisions about what should happen next. And that's part of this, how do we respond to that story? So again, if you don't do anything with the data, it doesn't really help. It certainly doesn't help your patients. So I think the other part of this is, so even if you have a provider who has the infrastructure to capture data, they understand how to interpret it, they can, understand what to do inside of treatment that's different as a result, you still have to have a partnership with your patient. And if you have patients who aren't seeing the value in those kinds of measures, then perhaps the provider's not using it as they should be. Anecdotally, I shared recently that maybe 6 months ago, I had completed my measures inside of the Arthritis Power app, and I took it to my rheumatologist and I handed it to the nurse who was doing my workup, before seeing the rheumatologist. And she said, "Oh, that's nice. I don't really know what to do with this, so why don't you hang on to it?" And of course, I responded, I know what to do with this. This is what you're going to do. You're going to take it, you're going to put it in my chart, and then when my doctor comes in, we're going to talk about it, because I think that something needs to change inside of my treatment, and I think this is helpful information. And I recognize that while I may be very comfortable having that conversation, there's many of us that aren't. And so, it really does take the partnership between both your provider and the patients to make sure that we have data at the right times and that we're really doing something with it. So, and Corey, that is the end of my slide deck. So I don't know if we have any questions.
Excellent. Ashley, thank you very much. I can take the control back, and we do have some questions, and so we can get to that. The first question comes from Beverly. Integrated care is really important, but should it include not just including different care providers like mental health therapists, a rheumatologist, or a primary care person, but also the time spent with the provider?
I just want to make sure I'm understanding correctly. I'm hearing integrated care meaning spending face-to-face time with providers. Hopefully you can put in the chat window if I'm misunderstanding that question, but yes, it does include that. There are different models for integrated care, and in what my experience is as a provider is that those conversations that we have with health plans really help us to understand how much face-to-face time we can spend and with whom, because not everybody in a certain population is going to have the same set of needs. So I, as a patient, may need a whole lot of face-to-face time with my providers based on where I am in my recovery or in my treatment, where somebody else who's been in treatment for a while may be functioning rather well, and so their needs are going to be different.
Excellent, thank you for that. Another question we have is, on the second slide, it said that approximately 68% of patients with mental illness have chronic pain. What would you estimate is the percentage of patients with chronic pain having a mental illness? But really, my question really is, do we know if one leads to the other in some way, or is it too difficult to say?
That is a great question. I'm sure I've heard lots of different answers, but so from a research perspective, we understand that those things are correlated. They're connected in some way, but it's we can't say beyond a shadow of a doubt that one causes the other. What we do recognize is that those who experience certain kinds of mental illness or mental health diagnoses do tend to report chronic pain with more frequency, and kind of vice versa. Those with chronic pain also report higher instances of certain kinds of mental health disorders, like depression is a good example of that. And so I could also well, as a provider, I think that's something that in the behavioral health space, of course, we hear of chronic pain pretty frequently, and there are reasons. Again, the presence or absence of a physical health condition plays a role. There are also indications around, like for those with substance use disorders in their histories, how certain substances actually change the chemistry in your brain and make you more susceptible to feeling pain, or pain feels more intense as a result when you discontinue use of that substance. And so there really are a lot of issues at play. As a patient, from a patient perspective, I guess I would add that just the presence of chronic pain. So in my own situation, I presented as someone with a physical health diagnosis and had no previous, and today still have no mental health diagnosis that accompanies that. But because of the situation that I was in, and all of the things that go with that. So chronic fatigue, plays a huge role in how we feel pain in our bodies and how severe that feels. And so, when I was feeling really, really bad and there was seemingly no end, there was no light at the end of the tunnel, I would say that the, struggling with depression or feelings of anxiety, for me, I was experiencing that quite intensely, where I really hadn't previously. And I do think that for, at least in that one example, that was likely a result of, living with chronic pain for what felt like an eternity. I recognize 7 months is not an eternity, but it felt like a really long time. So.
Thank you for that. Couple more questions. And again, reminder to everyone on here, if you do have a question, please send it into the chat box and we'll try to get them and answer them to the best of our ability with Ashley's expertise and knowledge. So the next question we have is, mental health is often expensive and not even covered by insurance. How can we talk about integrated care if mental health is so very expensive?
That's a fantastic question. Yes. So we recognize the same challenge as we are shifting. So as we're talking about integrated care, kind of on the behavioral health side, I would want this group to know that the same kinds of conversations are happening on the physical health side. And so I think the result has been that we have representatives from each of those sectors and health plans coming to the table to talk about how we might go about changing this. I think that that's a slow process. And so we are seeing in the organization that I work for, we are seeing new and different kinds of contracting opportunities that health plans are coming to us and saying, hey, we recognize that we haven't really been able to treat this particular population, or we haven't prioritized it, in the past. How can you help us to do this? So there are new opportunities. We hear major health plans, commercial health plans, Medicaid health plans, Medicare, they're all having those same conversations. So it is a slow shift, but I do believe that over the next couple of years that we'll start to see more and more of those opportunities present themselves.
That would definitely be the ideal scenario. The next question we have is, chronic pain has many aspects to it. It often leads to isolation, anxiety, depression, but this is because of the restrictions and changes it imposes on you. Someone diagnosed with RA or IBD or PSA, for instance, has to deal with a myriad of things. Wouldn't you say in these cases it is more important to address the autoimmune chronic pain disease condition that will then take care of the depression or the anxiety?
So I guess I think that depends on the individual, and yes, treating the underlying cause around the autoimmune disorder could help to resolve some of those. I do think that there's a more complex answer behind this. So the longer that you live with certain conditions, it can kind of change the way that your brain responds. And so if you're someone who's been living with that set of symptoms for 20 years, there may be kinds of treatment that you need access to in order to really help resolve those. Whereas if it's only been a couple of months, you know, or a year even, or, you know, that course of treatment might look different. So I do think it should be personalized to the individual, but I do think there's a role for both the behavioral and the physical health treatments inside of that.
That makes a lot of sense. Next question we have is, doesn't integrated care throw more people into the mix? Doesn't the system become even more fragmented? Now, I not only have my primary care physician, my rheumatologist, but also my counselor or mental health therapist, or et cetera.
So I don't think it makes things more fragmented, because the idea behind this is that all of your providers are talking with each other. And I would also say that it really depends on the providers that you have wrapped around you, really depend on what providers the individual needs access to. So that's why there's kind of like a patient-centered medical home, which is more of like someone with primarily physical health diagnoses, because they might have a different set of providers. So you could think about, you know, primary health, a rheumatologist, a GYN, if you have a neurologist, whoever it is you're seeing, it would be linking those providers together using care coordination. Whereas if you're an individual with a behavioral health diagnosis in addition to the physical health diagnosis, that's when you would really have some of these others come into play, like the therapist and those types of providers.
Gotcha. Another question from the audience. Does integrated care include alternative medicine or therapy like acupuncture, mindfulness, etc.? And if not, do you see this happening in the future?
We are not seeing that on the provider side. I don't know if there are other markets where they are including those things, but I'm not aware of any of them. I haven't also have not heard of intentions to start to include things like acupuncture. So likely not. Though I wish I could say something different. I wish I had a different answer for that.
It's the answer you got, and we'll take it. One more question. Integrated care implies coordination and communication across specialities and across diseases. Right now, our healthcare system is very fragmented. Do you really think that this is achievable? Sometimes my rheumatologist will not even know what medications have been prescribed by my GI.
Yes, I have also had that experience. I do think it's achievable, but I think it's achievable only if providers, and patients are continuing to come to the table to talk about how it might happen. I would not say that that's an easy thing, that integrated care is an easy thing to accomplish. But I do think that there's a lot of support behind it. And given even like the activity that we see at the federal policy level, I do think that we have decision makers around us who are really seeking to understand what it requires, and they are looking to remove barriers. And some of the barriers that exist are things that are even behind the scenes for a patient that feel behind the scenes about rules about what kinds of things you can bill in the same day, or what kinds of codes are there, or how to share information. So some of those barriers are systematically being reduced or removed through those kinds of policy efforts that we see, and through partnerships with health plans.
Gotcha. I do think there is one more question that came in. Hold on one second, just trying to get to that. Are there groups that are advocating for a combination of traditional and non-traditional medicine to be included into integrated care?
I think that kind of falls into that kind of alternative care category, and we are not seeing that being the case. I do think where we have interventions or practices that are now like there are evidence-based practices. So if I think about in the behavioral health space, mindfulness, that's something that over the last couple of years has emerged as a newer practice that behavioral health is trying to learn how to incorporate. Same thing with peer support services. So having access to a coach or a provider who has lived experience with either behavioral health or substance use disorders, or a number of ways that they're used. But I see those kinds of things being included in integrated health because they're supported by research. I see less movement for things that would be considered like alternative medicines.
Gotcha. Well, I think that's as good of a place as any to end it. Ashley, do you have any final comments or stuff, anything you'd like to add?
No, just to thank you guys for letting me join you this afternoon.
Well, thank you for being here, and thank you for providing us your expertise. And to everyone who joined us tonight, thank you for joining us. You all have a great rest of your night.
Thank you.